Welcome to Micromed Education, and today we are going to start our PG series, and the first lecture is based on the practical examination, that is a discussion of a bacteriological long case. In this we'll discuss how we excel, what are the expectation of a teacher from a student, postgraduate students, when dealing with a bacteriological long case. Let's proceed. So in your practical examination, generally you will be given a case history for a bacteriological long case. So based on the case history, one should understand which system is affected in this, like and what are the various differential diagnoses. Let's take an example in this case. Like a 10 years old boy is presented with fever. Also, patient has vomiting, altered mental sensorium, and one or two episodes of the seizure. And patient on examination has a knuckle rigidity. So, based on this case history, one can understand this is a case of which system is a central nervous system. So, the CNS is infected in this case. So, which are the differential diagnoses in this case? So the differential diagnoses are like this is a pediatric age group. The manifestation is of either meningitis or encephalitis, or raised intracranial trencher is there. So there are different differential diagnoses one has to put. Based on all this thing, if the history is given later, the CSF examination and etc. will also can be provided with the provisional diagnosis. In this case, we can keep it is up to meningitis. So, if we have kept in diagnosis of meningitis or anything like with different history, it becomes a different one. So, the next question goes like, what are the various etiological agents associated with this particular case history? So, this could be in this case, the various organisms would be there, but etiological agent in some cases it would be with the age wise, like we know in neonates there are certain organisms that cause meningitis. There is early onset meningitis, and there is also a pediatric age group. The different etiological agents would be there. The etiological agent will be differ when there is an immunocompetent patient or immunocompromised. Like we all know, in HIV reactive patients, the meningitis is mainly due to cryptococcal neoforming. So in this case, based on the case history, you have to understand that. We'll revise once again which system is affected first of all, then put a differential diagnosis, not a spot diagnosis. You have to think something else other than this also comes into the picture. Then your provisional diagnosis, another example we'll take, like a patient with fever, strep pyrexia is there, coated tongue, relative bradycardia. So you must be knowing that this is a case of enteric fever, but don't jump directly to the enteric fever. Put a differential diagnosis of fever, or if the patient was in the history also in manner, like patient has hepatosplenomegaly, put a differential diagnosis of hepatosplenomegaly with fever or something like that. So put like that more than one differential diagnosis. Then your provisional diagnosis in that case would be enteric fever. Then the etiological agent would be salmonella, not only salmonella typhi, paratyphi, A, B or C. So like this we have to go in case of case history. Now after the case history, you will be provided with a broth, and this is considered as your sample. Now this is a peptone water or any broth is given to you. So the next question what we expect, that is the macroscopic appearance. The next question would be macroscopic. So describe the given sample or the broth. So one has to mention whether the turbidity is uniform, particulate, is there any pellicle formation in this or not. Then the student will be advised to perform a microscopy. The two tests will be performed. The first one is your gram stain and another one is a motility. Always remember students, you have to ask your expert for the controls before proceeding to the examination. So in the cram stain, one has to take the controls and prepare the slide as mentioned in the this slide, that this smear has to be in the center with the positive and negative control. I'm not going in detail which controls will be taken, or you already know. This is Stepwise or E. coli can be used. So what are the question will be asked from the gram stains are, what is the principle of the gram stain, which are the various theories associated with the gram stain, what are the various modifications when it is used, and also then Viva can be goes on the cell organelles that can be observed from the gram stain, like a spore can be observed, capsule can be observed, and based on the various arrangement of the bacteria, please mention various arrangement, like Staphylococcus is in the cluster, Streptococcus in chain, Pneumococcus is the isolated Diplococcus with capsule. Like this type of question would be asked. These are the minimal questions that one expect from a PG student. Then comes the next test is your motility. So the hanging drop preparation would be there. I'm not going in the preparation, but so what are the Viva question that would be there in this is, you have to know the types of motility with the example, like what are the actively motile bacteria, sluggishly motile, darting motility. So various type of motility with example. Don't stick with the bacteria, also consider the parasites which has a motility, like falling leaf motility. Methods. In the methods also, don't stick with the wet mount or the hanging drop. There are around 7 to 8 methods that can be used for the demonstration of motility. That can be this serological method or a strain related methods. One very frequently asked question is difference between the true motility and what is the Brownian movement and their difference. Never mention in your interpretation of motility that I appreciate actively motile gram-negative bacilli. Remember, you cannot appreciate gram stain in the motility, basically in hanging drop. So what one has to mention is, I appreciate non-motile or motile raw. And then you can also mention that this rod are actively motile or sluggishly motile for any specific type of motility if you can observe, like tumbling or something. But never mention GPC or JNB. Then after you have performed your gram stain, you have done also your motility. So you know your history, you have your provisional diagnosis, you know the sample. That is also mentioned in your case history, that this is the sample from which the broth is prepared, like something. So which media you will take and why you will take this media. So remember, you have to take one differential media, that is McConkey's agar, one enriched media, that is blood agar. Here we will discuss first regarding CSF sample, that our original case, meningitis. So we'll take McConkey, that will differentiate lactose fermenting from the lactose non-fermenting bacteria. Blood agar, it is enriched media, that is required. Chocolate agar. Why we require chocolate agar for CSF? Because it require H. influenzae, pneumococcus, all this require, these are fastidious organism, and this require under CO2 and will be grown, H. influenza will be grown on chocolate agar, and that is the most common pathogen of meningitis. Why we take neutron agar? To perform various biochemicals or follow-up of this case. These are the selection of media. If your case is enteric fever, you will also ask for the selective media, like deoxycholate citrate agar, you can ask like that. And if the case is of Vibrio and diarrhea, you will take TCDS agar. Or you can also ask for the enrichment, like alkaline peptone water. So you have to understand first thing, which case is given, which are the additional media are, and you have to justify each media for that particular case. This is very important, and these are the various very common questions will be asked in the exam. Now after the media, the method. Understand, this is a broth that is given, but you have to consider it as a sample. So how will you proceed a CSF sample? Definitely, you will first centrifuge it, and from the sediment you will perform gram stain and the culture. Similarly, you have to explain that if this is a sample, then I will do this. So certain type of question can be asked. Like for Vibrio, a stool sample is there, so you will have to first do the enrichment. De-streaking method is also important. Like for endotracheal secretions or for urine, we'll do semi-quantitative method that has to be performed. So such questions can be asked. So we have performed our this case the first day, and the next day you will get the growth on your plate. So you should know the probable pathogen by the end of your first day, that is based on history, sample, provisional diagnosis, gram stain and motility. So in the long case generally 2 organisms are given. So you should know which one is pathogen and which one is either contaminant or colonizer. Like in a case of Vibrio, the E. coli will be a colonizer and Vibrio cholerae will be the pathogen. In case of enteric fever, most probably the Salmonella group of the organism will be the pathogen, and if the sample is blood culture, then generally the cones will be given as a contaminant of the skin. Most of the examiner, they will provide you the pure plate for the identification and putting the AST on the first string. So we'll okay, so after we know our probable organism, like probable, but that has to be confirmed with the biochemicals. So the selection of biochemicals as per our flowchart of GPC, GNB, and like whether it is fermentative organism, non-fermentative organism, based on that. So you have to mention the various selection of the biochemicals. What are the frequently asked questions from the biochemicals? Its principle, what are the controls used for this, like quality check of this and which gives positive control, what are the negative controls, and the preferred biochemical for the spot diagnosis in your case. Like if it is a GPC and catalase positive, so the slide coagulus will spot diagnose and differentiate between the cones or the Staph aureus. Oxidase test in case of Pseudomonas. Remember, even urease test you can quote, it gives within 4 hours in the protein. So certain things has to be keep in mind, and you have to select the biochemicals as per the availability at your particular site where you are giving the giving your exam. But try to cover the routine one and don't forget to put sugars as well. So in this case, first we will discuss the AST. So in AST, what is there? You should know your probable etiological agent. Now the probable etiological agent, how you can understand, that we have already discussed. But you have to remember which probable organism. Like we'll say it is a Salmonella typhi from blood culture. We'll discuss in this way. So you should know, as per CLSI, there is only few recommended antibiotics that is used for the antibiotic susceptible testing for the Salmonella group. The sample is blood. The blood and the sample is blood, so you know which are the antibiotics that should not be reported in blood. If the sample is urine, you should know the nitrofurantoin must be included in the your drug panel for organism like E. coli. So this point you have to understand, and then you have to ask your antibiotic to the expert based on the probable organism and the sample. Second thing, remember there are only 6 sticks are required per 100 mm plate, and always ask for the 0.5 McFarland standard, match the turbidity and then perform AST. Remember, there are certain drugs those are that does not have this diffusion criteria as per CLSI, that can be only done by the MIC. So in this case you have to advise to take E-strip or E-strip, that will help you. Also, one has to understand is the arrangement of the disc. Now understand, when we put a Staph aureus susceptibility AST, we know we have to keep erythroid clean the side to side for detection of inducible clindamycin resistance, as well as for ESP. Ceftazidime and ceftazidime clavulanic acid should be placed side by side to check the synergism. Like this thing one has to remember. In AST, the most commonly asked questions like what are the methods of the AST? Why Muller-Hinton agar is used? What are the various Muller-Hinton agars modification and their applications? Like for MRSA, what is the MHA modifications as well as the duration? Remember, for it's complete 24 hours. What is MIC and MIC detection methods? And my favorite questions would be, what is cascade reporting? What do you mean by BMQ and their applications? And what do you mean by CLSI and UCAS and how one should use them? So these are the points that one has to keep in mind. So at the end, one has to understand how we have to report at the end of the second year. So you have your history. Based on that, you have your probable diagnosis. You have gram stain, motility, biochemical identification of the organism. You know your pathogen now, and you know also your colonizer on the contaminant. So based on this, you have to mention that this can be used. And what is the AST of this particular organism? Interpreted this as SIR, STD and I caret. If you don't know this terminology, please go through this. This is very well mentioned in AMSP book by Dr. Apurva Sastry sir. So please check, it is very important. It is a frequently asked question. And if you can appreciate any phenotypic resistance from your AST pattern, that also has to be mentioned in your conclusion. And I would personally like to prefer what is the drug of choice in this case, if one can able to understand based on the history and the sample. So thank you so much. I think this will be useful too, and we'll meet in the next session, that is for long case. We have completed long case, and the next one is the short case of the bacteriology. Maximally similar to this, but there are certain things that one has to focus in mind for the short case. So see you there. Thank you.